Thank you so much. It's such a great pleasure to be here, and it was wonderful to listen to the panelists, because I'm seeing this all over the country where billing companies like yourselves really are making a difference based on the relationship. The billing is the easy part, and isn't it amazing how those relationships are extending far beyond billing to scheduling, patient access, and I think that trend will go on further and further. But there's a lot of competition, and I find the biggest competition in the market is fear. There's a lot of folks who are coming and talking to physicians. Join our ACO, our PHO. You have to be here. Come, bring all of your practice to me. Be employed. Oh my gosh, there are so many salespeople out there. And because of this fear, physicians, providers think, well, I need to get a shelter, of a hospital, of a health system, of an accountable care network, and we could go on with our alphabet soup from there. So one of the things that Kareo had asked me to do is to say, Elizabeth, it would be a great idea if we could bring our wonderful audience some information about how to build that relationship and perhaps how to respond to some of that fear that's going on in the market from a provider perspective. And so what I wanted to bring to you is, I tried to decide, was it State of the Industry 2018 or 2019? We're sort of in the middle. So we're going and taking a look at 2018 and how we moved to 2019. You heard a little bit about me. Maybe some of you are in the same boat. I fell into billing. For me, it started out with a proposal of marriage. Lovely gentleman. I happen to still be married to him a little bit more than 25 years now. But at the time, he was a first-year medical student. All my friends and family were like, oh my God, Elizabeth, this is the greatest thing. You're marrying a doctor. Your life will be set. This is awesome. And I thought, it's a really nice guy, and this is so cool. But oh my God, the debt. It was staring me right in the face. I had to pay this guy's medical school bills. So y'all, nobody else would hire me except for the billing office in the medical school and then residency program that he did. I'm not kidding y'all. Now, one of my first jobs at the billing office was the charge ticket runner. I had to make sure that I got to the orthopedics clinic on time because we only gave 2 appointment slots per day. One at 9 a.m., we scheduled 60 patients for that slot. And then one at 1 p.m. Oh yeah, another 60 for that slot. Imagine the patient and family experience. But indeed, those were the times I got kind of involved in the front desk and how to do that, where we hired receptionists to smile. That was it. Nothing else required. Just sit there and smile. And then, do you remember a few years later, we were like, all right, well, maybe we should check Medicaid coverage. That's all we did. And I was in Virginia, so we had papers. So we had a big meeting, I had to train all my receptionists to make sure that they got the Medicaid papers. That was it. Smile and get those papers. And then we started to get little things called co-pays. They were so cute. $3, $5, $10. Collect them if you can. Now, those were the times where I had physicians who said, oh my God, Elizabeth, you cannot train my people to get those co-payments because money and medicine do not mix. Absolutely. Absolutely. Now, on those little charge tickets we used to have, I did have a little tiny box our physicians could check. We had 500 physicians. And indeed, it said, I only. Anybody remember the I only? I've been in billing for a long time. I only, it's illegal today, y'all. We were insurance onlying everybody. Don't bill the copay. God's sake, no deductible, just bill the insurance company and write off everything else. Yeah, not a good idea today. And yet that was a time where we had 200 people in our business office. 2 were dedicated to patient collections. Now, it was a while ago, but you can see where times have changed, and times have changed significantly. And I think physicians who have come from that era where billing was really a back-end transaction. It didn't have anything to do with their business. We got paid more than, remember when we could bill a charge and we got paid a percentage of that charge? I still remember the fee schedule meetings that we used to have. They lasted about 5 minutes because we were like, oh my God, let's raise our charges by 3%. Somebody was like, no, let's do 8% because we got 8% more. And so, indeed, times have changed, and they have changed significantly. So we're going to start off with the top and kind of see what's going on or hear what's going on at the federal government level. And even if you say, oh, Elizabeth, it doesn't matter for Medicare, I'm pediatric practice, for example, but I do think the Centers for Medicare and Medicaid Services really sets the tone from a reimbursement perspective across the country. So what's going on at the federal level? And indeed, we heard the term PQRS and BACRA and the Quality Payment Program and meaningful use. Like, what does all that stuff mean? Because I do think there's a lot of fear, as you well know, from a compliance, from a regulatory perspective. Oh my gosh, what's going on? And CMS's announcements from just a few weeks ago that some of you may have heard about are creating an entirely another big swirl in the industry. And then we'll talk a little bit about reimbursement, and I'll end with what I think is perhaps the biggest issue in revenue cycle management, which indeed is patient financial accountability. Very different than the time that I came from. Well, we've had a very challenging couple of years in the federal level, and that has included in healthcare. And in fact, it may have almost exclusively been in healthcare. We've been on quite a ride. As so many of you know, President Trump did assign a gentleman, he was actually from my home state, Tom Price, an orthopedic surgeon, to be head of Health and Human Services soon after he was elected. He also assigned Seema Verma, who was from Indiana Medicaid, she was a consultant there, to be head of CMS. So we had Health and Human Services and we had CMS covered. Interestingly enough, within weeks, literally, of Price's nomination going through, Tom Price started canceling everything. Everything in the Obama administration. We saw cancellations of these episode payment models. I know for a fact, because I'm from his home state and work very closely with the Medical Association of Georgia, Tom Price was about to dismantle electronic health records, period. Meaningful use was going down, and he hated EMRs, and he was about to take them down. In addition to taking down those episode payment models, he had already made an announcement, this was about 4 or 5 months after he was in office, to really change the direction of the Innovation Center. And you may say, well, who cares about that? But the Innovation Center, which was actually created out of the Affordable Care Act, is the central body that all the stuff related to accountable care, value-based reimbursement, bundled payments, etc., is coming out of. So things were going down, and they were going down fast. Unfortunately for Dr. Price, he had a little hankering for private jets. And so that hankering for private jets got him fired pretty quickly. And so he was only in office, and I would argue it's probably good for us, because literally he was going to take down the whole thing, including automation in healthcare. So soon thereafter, we had a gentleman who came to us from Lilly, and that is the pharmaceutical company, who is the head of Health and Human Services. And indeed, Alex Azar put into place, even during his nomination hearings, if you can believe it. So everything that Tom Price had started canceling, Alex Azar started raising again. We saw these bundled payments for care improvement, but now they were advanced, BPCI advanced. And as the 12 months have come by, which is about the time period, now CMS, you may have heard, their big initiative is this Patients Over Paperwork initiative. We saw another 1,000-page document, because if you've ever had the chance to read any sort of announcement from the federal government, it always is over 1,000 pages. Now, somehow, the insanity that I have, In fact, it's, I guess, why I don't have a real job. I really enjoy reading these federal registers. And so the biggest news, of course, out of this patients over paperwork has to do with what is really the core billing codes for almost every single specialty. Even psychiatrists got to enjoy the pain of evaluation and management codes just a few years back. So our paperwork over patients, or patients over paperwork, depending on what you want to look at it, has made changes to our evaluation and management visits. And we got the signaling for this last year when CMS said they were taking a look at this. And for those of you who are coders, you know we use these 1995 and these 1999 guidelines to level the codes. It's a pain in the butt. I don't know how doctors do it. Many of them still carry around these cheat sheets. Or, of course, we seek assistance from our electronic health record systems. As you can see, the 10 codes that are kind of the core business, they're looking at reducing into 4. But most of the time we use our 99211 and 99201 for nurse. So really these 2 codes are 2 codes, one for established patients and one for new patients. On the surface, a very interesting and intriguing proposal. However, when you take a look at the actual reimbursement, you begin to sink into a deep depression, particularly if you are a specialist. So this will be a big change if this passes, that if we move to these 2 codes, which you can see have been chosen right about the midpoint, and if I'm a physician that really has kind of a usage on these higher level codes of the 99204 and 99205 and 214 and 215, this is going to be a very significant financial impact on me. So one of the things I would encourage you to do is to be aware of this proposal, maybe even consider, we know it will either go through or won't in November. That's when CMS will announce this, but I think doing an analysis, or at least being aware so that you can run an analysis in November or December for your clients would be most helpful for those physicians. Now, of course, coming out of Centers for Medicare and Medicaid Services is also our quality payment program. Our quality payment program stems actually from something that happened in, if you can believe it, the 1980s. So as I was kind of getting into billing, I was still there when we could charge and you got paid a percentage of that charge. But CMS had gotten, or HCFA back then, the Healthcare Financing Administration, had gotten word of this intriguing possibility of creating some sort of scale, if you will, that would be associated with the 7,500 CPT codes that we build. And they had contracted with the Harvard School of Public Health to have them create this scale. If the word scale and the late 1980s means anything to you from a billing perspective, of course what I'm talking about is the resource-based relative value scale. But during the development of that resource-based relative value scale that came into being really in the early 1990s by Medicare, and then it was soon adopted by most of the commercial payers, and today that RBRVS really is how we get paid, at least for professional fee billing. There was a mistake that was made, unfortunately, when the scale was converted to dollars. So as you well know, each year we wait for what's the conversion factor going to be, because that's going to tell us what Medicare is going to pay. And because many of our contracts are tied to Medicare, 105% of Medicare, 175% of Medicare, 77% of Medicare, that number is very important to us. And so speakers like me came to conferences like these for years and years and said, oh my God, CMS is decreasing its reimbursement by 30%. And then I would come back to you the next year and I'd say, oh my God, CMS is decreasing its reimbursement by 17%. And so interestingly enough, Congress actually had to step in 17 times and reverse those payment cuts. And it was all because of a mathematical formula, a flaw, a mistake that, well, maybe could be blamed on those Harvard researchers that converted the dollars in the wrong way. It had to do with the SGR, the sustainable growth rate. So some of you may have heard of the SGR and the SGR fix. Well, the SGR fix finally came in April of 2015. This piece of legislation was heralded by both parties, both the Republicans and the Democrats. Now, that piece of legislation is called MACRA, the Medicare Access to Care and Chip Reauthorization Act. But you might remember, oh, Elizabeth, I thought you said that was the Quality Payment Program. Well, they are actually one and the same. The law was heralded by the American Medical Association, all of the specialty societies. Finally, that SGR, that mathematical flaw is fixed, and now we will have a really, really solid Medicare rate. And that was true, but unfortunately, we didn't read past page 1. And past page 1, because remember, everything is 1,000 pages. Actually, I think this was about 300. But indeed, past page 1, there were a lot of words on those pages. And this quality payment program, which really was supposed to envelop the 3 programs that we had at the time, I'll say these words lovingly, meaningful use, PQRS, the Physician Quality Reporting System, and then my favorite, the Value-Based Payment Modifier. It's my favorite because how many of your practices participate in the Value-Based Payment Modifier? Yes, that's a trick question because all of you did. We didn't know what was going on. We were all participating in it, but who knew? We were out there trying to meaningful use everything. What do you need us to do now? The rules were changing. And so finally the government said, hey, listen, we're fixing that payment formula, that flaw, and we're also going to really wrap in those 3 different disparate programs into the QPP. Now, the QPP, which went out, and some people still call it MACRA, and the part that many physicians participate in is indeed called the Merit-Based Incentive Payment System, or MIPS. Now, a lot of practices spent a tremendous amount of time and effort participating in MIPS. It was rolled out in 2017, only about 18 months after it actually was implemented. Now, one of the interesting things to note is the rules have changed substantially in the past 18 months. Right after Tom Price came into office, remember he was shaking things up, he actually reached back to PQRS. It was interesting because one of our panelists says, well, the penalties aren't happening. Well, the reason that we don't have penalties is because Tom Price's administration actually went back in time and said, oh, if you didn't quite do what you were supposed to do under PQRS, we're having the penalties. But guess what? When we have the penalties, we also have the bonuses. So those practices that were actually doing really successful, unfortunately, they didn't get the bonuses that they were supposed to. So in 2017, you may say, hurricanes? What is going on? Wildfires? Why would we be talking about those when it comes to the Quality Payment Program, or MIPS? Well, the reason I'm talking about these is that about 9 months ago, so quite into the year, the federal government issued a regulatory advice that anyone who had been in a FEMA designated area, so this is any provider who was in a FEMA designated area in 2017, citing hurricanes, citing wildfires, but it could be any problems, was no longer subject to the penalties associated with MACRA or its program, the Quality Payment Program, or if you participated in the MIPS track. So 2017 participation wiped away about 20% of providers in the country. Why? My entire state, none of us are penalized. We had a rainstorm for a day. Woohoo, we got out of it. Florida, who had more than a rainstorm, but every single provider in Florida, no penalties. I could go on. Almost all of South Carolina, a lot of North Carolina, Alabama, Mississippi, Louisiana, and hello, California. And did I mention that many parts of Texas exempt from the program? The other thing that the government did this year was to say, hey, in 2018, we are creating a pretty significant level of exemption for small practices. So I don't know about y'all, but I'm thinking small practices. What is it, onesie, twosies? What are we talking about? Oh no, CMS's definition is 15. I never heard that used as a small practice, but I wasn't gonna say anything. 15 or less, right? So if you're a small practice, this whole meaningful use thing, you can exempt just because you're a small practice. So I'm telling y'all this because I am hearing so many people reach out to physicians. If you don't do this, if you don't do that, things are gonna be really bad. You're gonna get all these horrible penalties. Where, interestingly enough, if you are a small practice, you're already exempted out of one part of the program. There are very, very simple ways to participate on the quality perspective. And indeed, you also are exempted out of the requirements for the maximum requirements on the improvement activities. So I can work with a small practice and in less than an hour, give them a strategy to avoid the penalties and maybe even get a bonus. So this is something, particularly for those of you who do work with small providers, that you may want to think about as a value add. Now, the bad thing about the hurricanes and the small practice exemptions is in 2018, just about, it's been about 45 days ago, practices started to get their scores and their bonuses. Now, y'all have practices, I know, who worked so hard in 2017. They might have had hurricanes, but they said, no, we're gonna really keep weathering through, and we're gonna MIPS, we're gonna do it, we're gonna get our score, and they're so proud of their 100 points. I mean, oh my gosh, I've had so many, we've worked so hard. We've hired somebody, and here our score is 100. And so, like many of the programs that CMS does, this program is budget neutral. So all the PQRS, I mean, I could go on and on. This program is budget neutral. So what that means is the losers feed the winners. So I think I just mentioned that basically, gosh, about a third of the country is no longer being penalized. And so what that means is I don't have money to feed the winners. So I am not kidding y'all when I will tell you that I had physicians who were literally, and office managers, who were literally in tears when they got back their MIPS reports, because the absolute maximum bonus you could get was 0.02%. We got that little 0.02%. I should also mention that all of this chaos, all of this drama about this program, and that only gets added to your Medicare Part B business, not your Medicare Advantage. And so, oh my gosh, practices who had put tremendous amount of resources, scoring, so excited, and maybe they would get a check for $500, and that's it. So this is very important in my mind, particularly because, ironically, it is now simply making up our little friend called sequestration. You love sequestration, don't you know, on all of your remittances. Of course, Medicare takes 2%, not off of the patient's portion, but off of what Medicare pays with our friendly SARC CO253. And so our CO253 signals that 2%. And then for any of you who are in states that were impacted by the change with the gypsy and you got your 13 cents back, I was just in Iowa working with a big practice there, and they had 10,000 remittances that Medicare had repaid, and the average value was 7 cents. 7. So, of course, this is a complete nightmare because this is basically no money and 10,000 pieces of paper to work. And as you well know, sequestration, which was supposed to be there for just a couple of years, is now extended through a remarkable 2025. It doesn't help that our Medicare Advantage plans have taken hold of this as well and said, we like sequestration because it just simply means more money, in my opinion, in our pockets. And so even though Medicare Advantage plans have absolutely no legal right to take our 2% away from providers through their MA plans, Medicare Advantage, you see that, of course, ubiquitously through the country. They often take it as a CO104, managed care withhold. So our bonuses are not even, or at least breaking us even for the challenges related to our penalties. So I really think there's an opportunity for us to look at each one of these programs, particularly because we will continue to see, in my opinion, a lot of chaos at the federal level, at least for the next couple of years. We do know that the Quality Payment Program in 2018 has exempted any provider who has $90,000 or less in Medicare Part B, so it's Part B only, total allowed charges. So, I mean, unless you're in ophthalmology, cardiology, rheumatology, I could rattle off a few more, this may not even be a program that is relevant to you. But where there is fear, I think it is important for you to understand the program itself. We do know that meaningful use was changed to the term advancing care information. That term only held for about a little bit more than a year, because in May of this year, we do have a new term, and that you'll hear a lot, PI, promoting interoperability. But remember, our small practices are actually exempt from the advancing care information / promoting interoperability component of this program. So as they are being kind of wooed by all of these accountable care network salespeople, definitely want to make sure that you comfort them and hopefully really think about this program as a business case. What is the return on investment? Because a lot of practices have spent a tremendous amount of resources, and unfortunately the gain, the value just isn't there. So as a partner with these practices, sitting down and talking to them about what is return on investment. And I know y'all think I'm crazy, but I don't think I am. Many providers just don't look at framing the discussions with different payers, right? We're just so used to, we send in a HCFA, we get the money. We send in the HCFA, we get the money. That all of these new programs, I think the optics are truly important, particularly when we talk about the resources that are involved in participating in them. I've just shared with you the Quality Payment Program and the MIPS component of it, the Merit-Based Incentive Payment. There's other components if you join an advanced to alternative payment model. And hey, United has something, Cigna has something, et cetera, et cetera. So working as a partner with your practices on the business cases associated with these programs. Now, I want to flip and talk a little bit more about some of the reimbursement trends. We certainly are seeing a tilt towards primary care, and behavioral health is all of the rage. So we're seeing both Medicare as well as commercial payers that are turning their attention to behavioral health because, as you know, we heard from the panel, mental health billing, I mean, it is its own industry in and of itself. So I think behavioral health is, if you will, suffering a little bit because we don't have the billing down just right. That includes our chronic care management. This is a code or a set of codes now that we saw from the government, oh my gosh, now about 5 years ago, along with transitional care management, and if you're in primary care or hospitalist, etc., this is something you may be familiar with. But I find that practices are just really reticent to do this. It's non-traditional billing. Of course, our chronic care management codes rely on a monthly and a time cap. So you actually have to track time as well as the services that you perform. So it's a little bit different, funky. It's a little funky in terms of billing. But it's important for us to start thinking about this because we're seeing some major signals nationally that reimbursement is moving away from just this. You bill the E&M and you get paid XYZ. So we saw 99091, which in my opinion was a huge signal in 2018 now being covered. This is in essence the collection and interpretation of physiologic data. And what this means is the doctor can be in his or her office receiving information non-face-to-face with the patient and actually bill and get paid for it. Medicare did claim this to be 1.1 work RVUs, not a ton of money, but certainly a decent reimbursement. And I find working with physicians and kind of really training them, right? This isn't all about your 99213s and your 99214s. Let's talk about what else you do in your practice that today, if you documented it, goodness gracious, we could code and bill for it. So audits are wonderful, and I'm a coder and I've done the chart audits and it's lovely, but I think our real opportunity is getting in the exam room, sitting down with the physician and saying, what are you doing? I am shocked at the amount of work that physicians do that they have no idea that there could be a way to code and get paid for it. Now, there are compliance issues like our 99091. Medicare always puts in some extra little fun stuff. I can only bill it once per 30-day period. And I'm telling y'all about these as well because I think as you start these conversations, as billing companies, we have to be in a mindset where we're moving away from simply E&M, remet or claim, remet, and then payment. So this is really changing the tide for what we need to provide to our physicians. In July, the Centers for Medicare and Medicaid Services, in addition to coming out with those E&M coding changes, announced in their patients over paperwork that they would be 2 new codes. I love these. I mean, can you imagine these on a CMS 1500 GVC? What is that? I and one? Like, why are we even using I's and ones? Stop it. And yet GVC I1 is at least proposed our new code for basically virtual check-ins. And then GRAS1 is going to be remote evaluation of recorded video. So this is basically when we do a video visit with the patient, but interestingly enough, they have said it can actually be through the store and forward video. So it doesn't even need to be real time. So I don't know about y'all, but I'm like, oh my God, what does this mean? Like what? What does this mean? G codes, as you well know, are for Medicare only. So these are not real legit CPT codes, but they are billable by Medicare. And quite often when they go into the Medicare train, if you will, that the American Medical Association is reviewing them at the same time. And if they do become standard, then they'll move into the CPT code land. Reimbursement is changing, but how are we going to bill for this? What's the charge ticket? How is this going to come through to us as a billing company? These are the things I want you, and I've only given you a tiny fraction of all of the telehealth environment that is out there that I'm just starting to see physicians say, aha, this is something I could at least dip my toe in. In the meantime, commercial payers are getting even more complex from a reimbursement perspective. I don't know about y'all, but we used to have this big library and our memos would come in from our payers. And you remember when you could call a payer and you could like have a meeting with them. You had a little provider representative. You could call Lucy, and she was so nice. And that doesn't happen anymore. So we get these like issuance of United's gonna do this and Aetna's gonna do that. And you're like, are they really gonna do it? Oh my gosh, when does this start? And it's all kinds of insanity. Like this one is, Anthem, Blue Cross Blue Shield, and the specialty societies went nuts about this. Dermatology, ortho, they went crazy, crazy, crazy. Because what Anthem had said is, and they actually do this in several markets, is anything you bill with a modifier 25 or 57 is basically going into the multiple procedure reduction. And now CMS, y'all, interestingly enough, in that announcement just a few weeks ago, said basically anytime you bill 2 E&Ms, so think about in primary care all the time, we bill well child as well as a problem-focused office visit. If you bill 2 E&Ms, the second one will reduce by 50%. So that's CMS's proposal on the table. I mean, it is like mind-blowing to really try to keep up with all of these reimbursement trends. And I didn't even talk to you about the fact that, oh my gosh, the biggest thing that I'm seeing is the payers that are saying, you know what? Instead of, nitpicking all of this 25 modifier, 2 E&M stuff, what we're going to do is deny everything that hits over a certain dollar threshold. I don't know how many of you have clients like that, but I do a lot of work, for example, with a cardiovascular surgery practice, and literally we were talking about their denial rate and their first pass rate and blah, blah, blah. And it has sunk so low that their denial rate is about 85% now, 85%. And the reason for that is once we take our place of service in the hospital, we take out our 11s and just focus in on the hospital, everything is high dollar. And so their payers, they have certain payers who literally deny everything for medical records. That's it. Medical review, it goes right into it. We don't even want to talk to you until you send records. And so we're seeing a lot of this as payers really get very sophisticated with their bots, with their predictive analytics, with their profit margins that are so overwhelming. Really, what are these people doing with this money? My goodness. And my fear is they're putting more and more analytics towards us, and we're sitting there going, oh, CO15, where's that authorization? Sally over here, she was supposed to put it in the right field, but Sally was never even trained to put it in the right field because Lucy trained her and Lucy didn't know what she was doing either. So my fear is that if we don't step up our game, goodness gracious, our Sallys and Lucys are really, because I'm not talking about $1 here, I'm talking about a $15,000 surgery that if Sally and Lucy don't know what they're doing, I don't care how hard you work, you ain't getting the money. And so we've really got to think about working with our providers about this notion of, we've got to figure out not just how we're managing back here the transactions, and I know y'all do a great job of it, but indeed not just managing those denials, but let's figure out how to prevent them. So as part of your relationship, and I think this is a win-win for your organization, for a billing company as well, because the less we can let those denials end up as write-offs, the more, of course, that contributes to your profit margin. So this keep calm and prevent denials is indeed my big mantra in billing now, because I can do all the transactions on the back end, I can make it work, I can pay the people to try to call and get this covered. But my goodness, we've got to make sure we get clean claims coming out from the get-go. And that takes a partnership in order to be able to do that. One of my favorite reports to work with a practice on is the CAR report. At least that's what I like to call it. When we take a complete contractual adjustment, so we write off everything to United, Cigna, Aetna, etc. Why is that? Let's understand why we had to do. I'm not talking about it just got denied. I'm talking about it got denied. We work. We might have worked with a practice. We tried, and we ended up having to adjust it off. I find this is very, very important to work with providers on because it gives them a sense of where those opportunities are. Maybe it's not authorizations, maybe it has to do with registration with the front desk, maybe it has to do with services that are being performed in the hospital, that you get those face sheets. Oh yes, I come from a time where in the billing office, we would have ironing boards. And the reason, of course, we did is that our physicians would bring our face sheets and our charge tickets from the hospital. And then, of course, we would have to smooth them out. We actually literally had a smoothing station before we actually keyed the charges. And so, indeed, knowing where those opportunities are, I think is very compelling. Really placing analytics, if it's not this, then some analytics to identify those opportunities, because Cigna, Aetna, they're making it harder for us by the day. And based on the signaling from CMS, it's not going to be made up by giving us a little bit extra for our 99213s. In other words, our reimbursement is not going up. So we have to figure out how our partnerships can help. It helps to understand what those new trends are in terms of virtual medicine, et cetera, and working with our physicians about how we can implement it, as well as, in essence, working smarter. Now, of course, I think that some of this is challenged by the sheer complexity of medical billing. It really, you do have to be a little bit insane to be in this business, right? I mean, it just is like you have to be, between the regulations, and we haven't even talked about your labor, your workforce. Oh my gosh, right? You could have panels just about that, employee retention, et cetera. It is very, very complex, let alone the 70,000 ICD-10 codes and 7,500 CPTs, and that doesn't even account for the modifiers, as well as both the written and unwritten reimbursement rules. And yet, I think it's time for us to really think about working with our partners and saying, I love this little cartoon, how are you doing on your unspoken objectives? My what? Well, I'm referring to the goals I have in my mind that I've never mentioned. Well, how are those going? And Dilbert says, I'm totally nailing them. I love that cartoon. And I think sometimes really we have to take this to heart from a medical billing perspective. Because of the complexity, we don't always have our real goals in mind. I know we have our bottom line. I know we have our revenue. And yeah, we go out there with our days and receivables outstanding, et cetera, but we don't have, from a transactional perspective, how can we work with our providers to really create that win-win? So I think taking the opportunity, one of our panelists said how important accountability is. I think that is really vital, that accountability part to, as you're looking at your relationship, your partnership with providers, to really figure out what those goals are, to create that service level agreement. The expectations, as one of our panelists had said from the get-go, is important, and to constantly do that in your relationship, because the complexity is going to get even more so. Now, one of the most important trends, at least in my opinion, in medical billing has to do with a new payer in the market. And this new payer in the market is not really coming to us from Blue Cross Blue Shield of Arizona, although they're probably very aggressive as well. Of course, this new payer that I'm talking about is the patient. And so I come from billing where, as I mentioned before, we didn't really care about patient financial responsibility. Out of our 200 staff members who worked in our billing office, we only had 2 dedicated to patient collections, and literally their job was to write things off. Right? I mean, small balance adjustment. We didn't small balance any, we just adjusted things off. We didn't really care. And those were times, I mean, some of you were in billing 25 years ago. We had plenty. We had plenty coming in from insurance companies that it just simply didn't matter. And yet, indeed, it was such a trickle of dollars for us back then that we didn't deploy our processes to really make a difference. So y'all, we have some significant catch up to do. So that new payer, I like to think about that payer in health plan terms. Y'all know, for example, that working workers' comp claims is totally fundamentally different than working a Medicaid plan or working, my gosh, this nice and easy Medicare Part B. Well, let's think about our patient as a payer with our 3 health plans. Our first health plan is our Happy. These are our patients who you don't need to do anything with a Happy. They are going to pay, they're going to lead with their Visa card, no worries at all. But then you have the Nudger. And the Nudger is in a health plan that it's kind of have a different strategy for it. So techniques like working with your practices to say, you know, when a patient with a balance, yes, did you know we actually have a word called a balance? It's that thing sitting on your computer screen that means you need to try to collect it. And I know that sounds a little crazy, but I'm amazed how many practices do not collect balances. Now let's think about this, right? That patient knows. I bet they even have the statement in their purse. They know that practice owes them, they owe that practice money. I mean, it's a done. They know it, right? And they're just waiting. They're waiting. Oh no, you don't say a word about it. Now our Happy is the one who's going to be like, oh, I got it right here. I got a statement from your practice. I would like to pay it. I was at a family medicine practice. I was just sitting down, observing, and the receptionist said, not my job. Not my job, right? You can drive, I'm not kidding you. You can drive down. It was like 2.3 miles away. She gave them instructions about where she could go and take her check. I'm not joking. And so, I mean, our Nudgers are like, right, if you don't ask me, I'm going to walk out of here and I am going to think 100% I no longer owe that balance. Because I was standing in front of you and you didn't say a word to me. Not a word. So any practice that says, now Elizabeth, I mean, really, do you think our front office is really going to collect anything? I'm like, y'all, this is not just about collections. This is about expectations. This is not just about collections. This is about expectations. And we need it for our Nudgers. Our Happies, I agree. If you are at a practice, one of your clients is all happy patients, you don't need this. But our Nudgers need a little something. So they've got to have that balance. They've got to make sure that when the patient is walking to the front office, they're looking on their person for something to compliment. Miss Woodcock, lovely suit you have on today. How would you like to take care of your copayment? And you think I'm crazy. It's true. It works. It's great. It's great. Just like, oh my gosh, the computer tells me, it's not me, the computer tells me you have a small balance of $1,700. It's not me, it's a computer. And you know, these are the little techniques. You don't need them for Happies. Who cares? But for Nudgers, you got to go out there and you've got to have your game on. So this is something I would really encourage you to work with your practices about, because y'all, this stuff you know better than me. It is 10%, 15, 20% of some practices AR. Of course, even Medicare now. I mean, if you don't have a Medigap policy, these Medicare patients, this is 20% co-insurance, deductibles kicking in. So anybody used to tell me, well, I'm all Medicare, I don't have to worry about that. Oh, you do have to worry about that, big time. In fact, they're almost all Nudgers because they've never paid. They've never paid. And then, of course, my favorite health plan, those patients who have literally no intention whatsoever of paying. No intention. It may be an unwillingness, it may be an inability, I don't know what it is, but these patients are evaders. And one of the things I would say about evaders is they cost you so much money. You so much money. Oh my gosh, I was with a physician, a pulmonologist, wonderful gentleman. He said, you know, Elizabeth, I have sent this patient, hospital consult, has sent this patient 28 statements. How many more should I send? Right now, we've actually spent more in postage than indeed we're ever going to get from any patient. And he is wallpapering his kitchen walls with those pieces of paper at this point. It ain't gonna work. He's an evader. So we've got to also think about this concept of the return on investment. What are we going to do with a business case about each one of these health plans? How are we going to attack this within the practice? And we have to, because we used to think about patient payments it's just really a self-pay issue, but it's not just a self-pay issue. In fact, I find a bigger problem, at least from an expectation perspective, within a practice for patient financial responsibility after insurance. Patients are not paying their deductibles, their co-payments, and their co-insurances. Patients are not paying them. And until we get our game on, that money is just simply going to be lost as bad debt. And that bad debt, as you well know, in the hospital environment means something. Right? It means something. If we're in an assisted living facility, a nursing home, it means something, because what we can do is turn that bad debt in as charity care to the IRS and say, pretty please, I need dollars off my taxes. It's a tax advantage. If you are in a facility, charity care is a tax advantage. Once we move into the professional fee setting, it no longer becomes a tax advantage. And the reason is because our greatest asset is time, right? That's what makes, in my opinion, medical billing so hard, because we don't have a thing. We don't have bricks and mortars. We don't have a tangible item. We have time. We have time. And so from a tax advantage perspective, we have none whatsoever to turn any of this in to the government to benefit. And what's fascinating is you have to stay on your toes as well, because patients are changing health insurance plans all the time. Now, I think this data, 22 to as much as a quarter of your patients when they show up to the practice indeed have changed health plan. Why so high? Because for some reason, I have not researched this, but when a person is laid off or fired from their jobs, they go see a doctor. Have you noticed that? I don't know what the deal is, right? All of a sudden, they get laid off and they're in a doctor's office. It is an odd situation, but I'm sort of joking, but I'm actually not, in that we have a tremendous amount of changes from a registration perspective. And this whole idea of, well, we'll just check once a year, right? That'll be plenty. You cannot have that protocol any longer in professional fee billing, or you're not going to have the correct registration information. You simply will not. And then what do? I love it. We send even our nudgers these beautiful statements. They get a statement in the mail. Just let that be a mic drop. Nobody even has a mailbox left anymore. And yet we're like, oh my God, let's mail them. That's a great idea. So we're mailing these statements. And let's think about this, right? There is literally nothing we can do to a patient. We can't turn the lights off. We can't cut off the electricity. We can't turn their cell phone off. But we have nothing we can do. So the patient gets, oh, and that's sweet. Yes, $100. So our bill always goes to the back of the line or in the trash can right away. And then we're like, oh my gosh. So let's go ahead and send another statement. And fascinating. It's still $100. The patient's like, oh my God. And there are 3 more boxes to go. So I'm definitely throwing this one in the trash can. Gone. And it is sort of funny, like when you look at statements, I'm gonna tell y'all 75% of the time, we don't even put due dates on them. Like, pay us in 10 days, 2 weeks would be great. Maybe a little sticker, pay now. We don't actually have due dates. We don't do a particularly good job, in my opinion, of making sure that our statements are going out. And then, as I mentioned, my goodness, We rely on the United States Postal Service. I think the United States Postal Service would be devastated if something happens to us from a statement perspective, because I don't know anybody else who uses them to send out invoices. I mean, even like public works, local governments, they're way ahead of us on this. And we're spending a pretty penny. It's not like we're going down to the post office and be like, oh, please, can we send our statements for free? No, they cost money, about $8,000 per provider. So these are the ideas that we need to really sit down with our providers, with our practices, with our physicians, and talk about the business case. Talk about the health plan, our 3 products, and how in my practice are we going to work with this? Because each one of your practice clients are a little bit different. If you have emergency medicine, completely different set of patient financial accountability issues than you would, for example, in a community health center. If any of you do FQHCs or RHCs, totally different. So really working with each one of your practices to determine that patient financial accountability strategy, because the patient is defining our revenue cycle success. This is really an important trend that unfortunately we have not yet embraced. We're still out there kind of thinking somebody else is going to do it. And of course, the somebody else who's going to do it is quite often you. And I really fear that unless we wrestle with this and really create some performance improvement opportunities, that our practice is going to lose, as well as you. So we've talked about a lot of different ideas, that state of the industry, running through what's going on at the federal level, and a little bit about that quality payment program, or MACRA, or of course its component called MIPS. And then we delved into some of the reimbursement ideas, looking at the challenges from commercial payers, also recognizing those new trends on the horizon, like the CPT codes, for example, as well as all that virtual care that is now coming into be. And then, of course, we took a lens on the patient financial accountability and really thought about some of the tactics that might work for you to work with your practices. Well, I want to thank you all for the opportunity to be here to speak with you today. Thank you.